You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about right ventricular function. We'll talk about RV size, RV systolic function, and RV systolic dysfunction. The crescent shape of the right ventricle, the RV's position behind the sternum, and the lack of specific right-sided anatomic landmarks to use as reference points makes it difficult to consistently quantify an echo. The cardinal right ventricular linear measurements are as follows. In a right ventricle focus A4C view, the RV basal diameter, which is the maximum width at the basal one-third of the RV, measured at end diastole, should be 25 to 41 millimeters. The RV mid-diameter, which is the width halfway between the level of the maximal diameter and the level of the RV apex, measured at end diastole, should be 19 to 35 millimeters. The RV longitudinal diameter, which is the width from the midpoint of the tricuspid annulus to the RV apex, should be 59 to 83 millimeters. Measurements should be obtained in an RV focus A4C view, where the transducer is rotated slightly counterclockwise, tilted, and sometimes also moved medially to maximize the RV area. The TAPSE, which is covered shortly thereafter, is also measured in this view. In the PLAX view, parasternal long axis view, the proximal RVOT diameter, which is the width of the RV outflow tract measured from the septal aortic junction to the RV anterior wall, should be 20 to 30 millimeters. The proximal RVOT diameter is more dependent on imaging plane position than the distal RVOT diameter, so it is not as reproducible. In the parasternal short axis view at the aortic valve level, the proximal RVOT diameter should be 21 to 35 millimeters. In the pulmonary artery focused parasternal short axis view, the distal RV outflow tract diameter should be 17 to 27 millimeters. For two-dimensional area measurements, RV end diastolic area and end systolic area should be obtained by manual tracing of the RV endocardial border from the lateral tricuspid annulus along the free wall to the apex and back to the medial tricuspid annulus along the interventricular septum. Trabeculations, papillary muscles, and the moderator band should be included in the RV cavity area. Now let's talk about RV systolic function. Because the RV is such an odd shape, geometric formulas for RV systolic function are challenging. Instead, only a qualitative evaluation, normal, mildly reduced, moderately reduced, severely reduced, is given based on simplified measures, including tricuspid annular plane systolic excursion, TAPSE, tissue Doppler peak systolic velocity S' at the tricuspid annulus, RV fractional area change, or FAC, and RV index of myocardial performance, or RIMP. Let's start with TAPSE, which is the tricuspid annular plane systolic excursion. Measured in A4C using M mode on the lateral tricuspid annulus at end diastole and end systole, TAPSE is the number of centimeters that the RV shortens longitudinally, tracked by the distance that the tricuspid annulus moves towards the RV apex from end diastole to end systole. TAPSE more than 16 means that 16 millimeters means normal RV systolic function because the RV is moving adequately. Normal TAPSE is 24 plus or minus 3.5 millimeters. A failing RV, such as in end-stage cor pulmonale or severe pulmonary hypertension, almost never has a TAPSE that is higher than 1 centimeters. TAPSE of 16 millimeters or less suggests RV dysfunction. So you remember 1.6 centimeters is the cutoff. Lower than that is RV dysfunction by TAPSE. Advantages of TAPSE are that it is easy to measure and isn't affected by dropout or trabeculations. As a one-dimensional measurement, TAPSE and S' velocity, which I'll talk about next, both suffer from being influenced by the significant variation in chamber orientation between patients and is also affected by preload and afterload. If TAPSE or S' are not measured parallel to the plane of motion, they will be underestimated. TAPSE is inaccurate in AFib and mechanical ventilation. Now let's move on to the S' velocity. This is measured in A4C using tissue Doppler imaging on the lateral tricuspid annulus. In the same position as that for TAPSE in A4C, switch from M mode to tissue Doppler interrogation of the lateral tricuspid annulus. The first positive velocity that appears after the tricuspid valve closure represents the isovolemic contraction, and it is very brief in that you won't see it unless you stare at it. It is followed by a much larger positive velocity named S', which refers to the peak RV systolic excursion velocity. An S' that is less than 9.5 centimeters per second indicates RV dysfunction. After PV closure and before TV opening, the first negative velocity represents the isovolemic relaxation, which is very brief, and is followed by two much larger negative velocities: early, which is big E', and late, which is big A', negative diastolic velocities. Let's move on to RV fractional area change, or FAC. This is traced in A4C at end diastole and end systole. RV fractional area change involves the RV endocardial area tracing in both end diastole, which is when the ventricle is largest, and end systole, which is when the ventricle is smallest. The RV apex and lateral wall must be included in the imaging plane. Normal RV fractional area change is in the 32 to 60% range. 25 to 31% is mildly reduced, 18 to 24% is moderately reduced, 70% and less fractional area change is severely reduced. Any fractional area change less than 35% indicates RV systolic dysfunction. One advantage of fractional area change is that it is two-dimensional instead of one-dimensional, so the errors are not squared. One weakness of using this method is that it still is preload and afterload dependent. Be sure to avoid undertracing the cavity inside trabeculations or the moderator band. Then we have the RV Index of Myocardial Performance, or RIMP, RIMP, also known as the TEI Index, TEI. It is measured using PW of tricuspid inflow in the RV focus A4C and PW of the RV outflow tract in RVOT tilted parasternal short axis. Or it can be measured using TDI of the tricuspid annulus on the RV free wall in the RV focus A4C. Tricuspid valve closure opening time, or TCO, which is the time from the end of the A wave to the start of the E wave on PW of the tricuspid flow, is the summation of three things: the IVCT, ET, and IVRT, the sum of the isovolemic contraction time, ejection time, and isovolemic relaxation time. Ejection time is the systolic flow time through the pulmonic valve, namely the time from the onset of flow to the end of flow on PW of the RV outflow tract that leads to the pulmonic valve. RIMP is the ratio of the RV non-ejection time, that's the IVCT and the IVRT, to the RV ejection time. IVCT plus ET plus IVRT comprise the tricuspid valve closure opening time, or TCO, also known as the isovolemic time. A RIMP that's more than 0.43 by PW or a RIMP that's more than 0.54 by TDI indicates RV dysfunction. However, doing RIMP by PW alone requires two different acquisitions and cardiac beats, leading to error, especially when there's irregularity between cardiac cycles. On the other hand, if RIMP is done using TDI, you can acquire both the TCO and the ET using the same cardiac cycle. In RV Focus A4C, you can achieve this by applying TDI on point on the tricuspid annulus that is on the RV free wall. One advantage of RIMP is that because it is a ratio of time intervals, its determination is independent of the geometric shape of the RV, which is complex to model. That's all for right ventricular size and function.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.